for those that have to drop out early, I want to put my little virtual background up here. And then I am going to bring on our good friends at Inspirations, Ben and Casey. They are our September sponsors, and let's see who they've got for us to meet today. So if you haven't been on these calls for the last 3 weeks, 2 weeks ago, we met some baby chicks. Last week, we met some llamas, and it looks like, what do we have here, Ben and Casey? Oh, wow. Who do we have today?
So today we've got our group of goats out here, our herd. We have a couple of residents out here with, I'm Ben, for those that don't know me. Casey's back here in the blue. And we have our residents joining us today. And we have Christina, our director from Westminster.
Hey,
Great. I haven't seen Christina in quite some time, so it's great to see her. But and it looks like you got the llamas there too. So this is awesome. And then just for everybody, pan up to your community there in the background.
Sure.
Yeah. So this is
behind us.
Yeah. These guys have 3 really innovative assisted and memory care communities, and Ben and Casey were consultants for many years, and what they did was they pulled all the best practices that they've seen at all these communities that they visited, and one of the things that they've really embraced is allowing the residents to engage on a daily basis with the animals, and it's just mind-blowing what you've got there.
Well, thank you. Yeah, that's not too often you hear of a residence care plan that has feeding the goats or feeding the alpacas included in their care plan. Yeah. So it's pretty fun. It's fun to have animals. Lots of people had animals growing up. A lot of people can relate to them in some way. And so whether it's chickens, goats, dogs, cats, birds, it's fun to include them.
Great. Well, really appreciate you guys supporting us during September, and I'll reach out. Maybe I've been thinking that maybe next week I'll come up there and do and visit myself and see if I can figure out how to do one of our broadcasts live from that location. That would be really
sure.
That'd be great.
Yeah, that'd be great. Sounds cool. Fantastic.
All right, guys. Well, get back to working on the farm there, and we'll see you next week.
Sounds good. Thanks, Steve.
Good to see you.
You bet. Okay. All right. Well, that is really a real treat, and we've got another real treat for you today with our program. I'm going to bring on Melissa. Melissa, how's it going?
Hi, Steve. It's going very well. Thank you so much for having us on today. We're very honored to be here.
Yeah, so this topic today, guys, is in COVID-19, as we know, one of the most challenging and emotional aspects is sort of end-of-life issues. And I was speaking to Melissa, over a month ago, and we've been coordinating to feature, some of her doctors, hospice physicians, and brought together this program for you today. But before we introduce Dr. Richmond, Melissa, I'm going to bring your team up, and while I'm bringing them up, if you want to give the audience a little overview of VITAS and how your team works in the region.
Sure. So Steve is about to pull up about 8 team members. So we cover in this region all of DC and Northern Virginia. And once they're all up on screen, I'll go through the names and have everybody give a wave. But VITAS, we're actually a national company. We're the largest single source provider of hospice services. We have over 11,000, actually nearly 12,000 employees. These are our 2019 statistics. We have over 4,000 volunteers. We average about 5 to 6 patient visits per week. And the team here that you see covers all sorts of accounts in the area. So we're calling on physicians, hospitals, assisted living communities, nursing homes, and just the community at large, with the main goal of just advocating for hospice and people accessing hospice services. So I'll go through our team here. For our DC team, we have Makia, if you can just give a quick wave, and Leo. And then our Virginia team, we have Rusty, Rosa, Marianne, Michelle, Sarah, and Brad.
Awesome.
So they'll be on the chat box. They can share their info there on the right-hand side, covering DC and Virginia. If you guys have any questions here locally about VITAS, we're more than happy to be in touch.
Fantastic. Well, that's great. And thanks guys for coming out today. So if you can just hit your little video button. I'm gonna bring on Dr. Richmond while you guys are dropping off the screen. And let's see. All right. Dr. Richmond, thank you. Oh,
Hi.
did we lose Melissa? Oh, okay. Okay. Hey, okay, Melissa. Yeah, thanks. Well, again, thanks for bringing us Dr. Richmond and for this important topic. And we're really psyched to get to know you, Dr. Richmond, and sort of hear a frontline view of what it's like being a hospice physician in this challenging time, and have an engaging discussion with our audience. So just as a reminder to the audience, just type in your questions in the Q&A box, and we'll make sure that Dr. Richmond gets it. Melissa, did you have anything else you wanted to share before we jumped into the discussion with Dr. Richmond?
Yes, actually, I just wanted to show a brief video, kind of recaps VITAS and how we function through COVID-19. So then Dr. Richmond could go into more detail about how we function locally. So if it's okay, I'll go ahead and share my screen.
That's great. And what I'm going to do is I'm going to mute both myself and Dr. Richmond when you show this.
Okay. Can you just confirm, can you see my screen? It's a blank white. Good, okay. All right.
As the nation's leading provider of end-of-life services, VITAS Healthcare cares for over 19,000 patients in their preferred setting of care. During the COVID-19 pandemic, our care remains constant. In the age of coronavirus, our first priority is to ensure the safety of patients, employees, partners, and the community. Our resources, expertise, and mobility-first approach provide uninterrupted support. Our team can leverage telehealth capabilities to evaluate your patients for hospice eligibility, coordinate rapid care transitions, and execute individualized care plans for each patient, including spiritual and psychosocial support for loved ones. At VITAS, we are educated. Our infection control practices meet CDC and state health department guidance for COVID-19, while incorporating additional precautions. Each workday, our employees report their temperature and symptom assessment through our app to ensure a healthy workforce. Every VITAS location has an infection control manager armed with the necessary COVID-19 knowledge and real-time access to our proprietary risk assessment algorithm. These measures protect our staff, patients, families, and partners in the event of an exposure. At VITAS, we are committed to you as a partner in care. As your community partner, we train our teams to follow your facility's procedures and to incorporate your standards into our care model. we continue to uphold all components of our contractual relationships, including our 24/7 year-round availability to your staff who deliver our patients' care. Above all, at VITAS, we are ready. The VITAS mission and core values have solidified over 40 years of supporting our partners to care for hospice-eligible patients, regardless of diagnosis, complexity, acuity, or social circumstance. We have weathered hurricanes, earthquakes, wildfires, and national tragedies. Through it all, we stand by our communities and healthcare partners, ready to admit and transition hospice-eligible patients anytime, day or night. Whatever change tomorrow brings, VITAS remains a constant. When it's time for hospice, it's time for VITAS.
Great. That was great. And hopefully the audience could hear. Sometimes I know the audio is not the greatest with video, but I think that worked out pretty well. So thanks a lot, Melissa. And let's see. So let's get to the discussion here with Dr. Richmond. So Dr. Richmond, I see from your bio you were raised in Miami and came up here to school to UVA and GW, and you never went back. And as we move into the winter season, I know you're probably missing that Miami temperature.
Yes, very much so. But I think I've been here long enough that my wardrobe has acclimated very well. So I look forward to dressing for all 4 seasons. Excellent.
Well, you've gone into a segment of medicine that's very important, you know, hospice and palliative care. What drew you to that as a profession with all the different options out there?
Yeah, well, my specialty is internal medicine, and I started out as a hospitalist at Holy Cross Hospital. And then I had a wonderful opportunity presented to me where I joined a nephrology practice and became the lead physician in taking care of patients facing end-stage renal disease, chronic kidney disease, and patients who are on the transplant list. A part of my requirements or my obligations was to round in nursing home facilities. And in doing so, I encountered many patients who were residing in nursing homes, back and forth with a revolving door of in and out of the hospital setting and environment, and on a slew of medications exceeding pages and pages. I ran into a woman who was contracted with another hospice organization, and I shared my concerns, my issues about patients not having a voice when it came to their care. Patients receiving aggressive interventions when it wasn't bringing about comfort, but actually a little bit more of discomfort, I would say. And that's when she presented an opportunity to join their hospice organization as a team physician. I was with them for a few years before meeting with Dr. Ladisa, who's actually my best friend, who presented another opportunity for me to join the VITAS family. I've been with VITAS now for almost 10 years, and I love it. My roots are here. I've gone on and earned my hospice medical director board certification as well, and recently renewed. And I would say that along my journey, what I have found is that in the field of medicine, as you said, there are so many opportunities to help people. But I think that this particular area of medicine is so intimate and is so strong, and it promotes wellness even as we know that our loved ones are passing on. It gives me an opportunity to integrate and become acclimated with families in a different way, and giving a voice to the patients and their families, and them deciding what comfort looks like for them. Mm-hmm. And I've never looked back, and I love it.
That's great. And I hope that we can recruit more young doctors like you into this field, because as you know, it doesn't necessarily present itself as the sexiest, Correct. Especially in COVID-19, but really meaningful. So So with that, kind of, can you give us sort of a glimpse of a day in the life of a hospice physician? What was it like, sort of being hit with COVID-19? It's already challenging. And now, we're dealing with quarantines and families that can't see their loved ones and a whole variety of different issues.
Right. I think what we were hit with initially were a lot of questions. Many, many family members calling and inquiring if services would be discontinued, if VITAS would stop caring for their families, whether they were located in a home, whether they were located in a nursing home, assisted living. And what we did first and foremost was assure them that our services would continue. And as you can see in the video, what we do is we adjust to the environment that the patient calls home. So in setting up meetings, so our meetings initially took place amongst each other, VITAS with our local programs, the DC and Virginia program, VITAS nationally, and on a day-to-day basis. As the information was being released from the CDC, that information was instituted in our meetings, and first and foremost, the PPE was a priority to allow us to continue to provide and giving care and good care to the patients and their families. We met with the nursing homes and the assisted living facilities, and many of the physicians in our programs still have our care. We still provide care for our nursing home patients. I still serve as medical director in nursing homes in the community and environment. So we met with the nursing homes to determine what was the scenario for them. And I can speak about one particular nursing home. They were hit hard, so they immediately shut down. They shut down. Everyone was encouraged, and everyone needed to have a COVID-19 test. They set up stations outside of the facilities, encouraged family members. We will continue to keep you abreast via phone, via telemedicine where you're using your FaceTime option, but please, we encourage you not to come into the facility. Once we were all deemed COVID negative, the facilities allowed the nurses for VITAS to continue to provide care. Our VITAS team was that direct connection for the families on the outside and their loved ones on the inside. We increased our visits to the patients in the homes, in the facilities, in the assisted living centers, as long as we were allowed to. We continue to have testing on an ongoing basis. Myself making rounds in the community and in the homes, wearing my PPE, in the facilities, having my COVID-19 testing, and also via FaceTime, because many families want to continue with our services. However, they were afraid. There was a lot of apprehension about the traffic coming into their home. So we adjusted and we came into their home via FaceTime and telemedicine. We still prescribe our medications electronically. And what our pharmacy operations did was they upped their availability for certain medications. They upped their availability to have medications transported out via FedEx to the patient's homes. And we also connected with the local contracted pharmacies as well. We have ongoing education that all of the members and all of the family members of VITAS must stay abreast. Hand washing, wearing, I have to use my mask, but putting your mask on and even taking it off, and encouraging the proper hygiene and how to use your mask. And some of these things I would say, we may say, oh, I already know this, but you would be amazed about the take-home messages you find with this intimate information that not only protects you as the caregiver, but it also protects the patient and their families receiving the care. We also really, really focused on our hospital settings because they were getting bombarded with patients being transferred from the outside, from the community to the hospital. What VITAS offers is our general inpatient care. This is our highest level of care where we provide hospice type atmosphere and care for those patients who can't provide that care for themselves in a home environment. Many patients passed away from COVID-19. COVID-19 was deemed an acute illness that fell under the hospice umbrella. So we were able to care for each and every patient who was diagnosed with COVID-19 and their associated comorbid symptoms, and provide care for them and educate the families as well. So it was all hands on deck, literally, and outreaching and reminding everyone that we were still that source of foundation, that source of connection, and that steady source of care.
Wow. No, I mean,
that was
one
a
thing,
mouthful.
oh no, but I think we're all experiencing having to sort of reinvent the way that we deliver whatever services that we're delivering. But what's really interesting is that as challenging as this has become, is that we're becoming more efficient.
Yes.
We're in some cases, we're delivering better service now than we may have been pre-COVID. But we always, for these discussions, we always have a wide variety of audience attending. We've got a lot of professionals, but a lot of times we have families and older adults that are tuning into these. Could you kind of like walk us through what does hospice and palliative care treatment look like? I mean, you know, maybe I know there's not a typical case, but when somebody calls, you know, VITAS or another hospice, what is the expectation? And the other thing, I know I'm babbling, okay, but the other thing for us as providers, what I hear too often from hospices is we don't get contacted soon enough. Like, you know, oftentimes by the time a family or a referral source picks up the phone, it's sort of like, it's a little bit too late. So I know I asked a bunch of things there, but maybe it's sort of giving us sort of a case study or a scenario to help us better understand the services that you're providing.
Yeah, and you know, as you stated earlier, Steve, that hospice really doesn't appear as a glamorous, you know, area of medicine for providers or clinicians. And working with residents at the local hospital and medical schools, I think they see, you know, the fresh face of hospice today. What I can also say is family members also share that same reluctance. When you hear the word hospice and palliative medicine, oftentimes it's associated with death. It's associated with giving up. It's associated with a lot of negative feelings. When we receive a call at VITAS, or when Makia or Leo or Melissa present us with a possible referral from the community and the hospital, the first thing we do is we call not only the provider who's giving the referral to introduce ourselves and also to inquire about the hospice evaluation that's being requested, but we call the patient and their family and introduce ourselves. And we share that we've been asked to now come on board and take part in caring for them. We are now creating a bigger circle and a bigger environment and a more holistic environment. We set up an appointment to meet with the family. We also ask the hospital and or the provider to provide additional clinical information to support their concern for hospice care. That's reviewed by myself, the patient care administrator, who serves as, it's very synonymous to the director of nursing. So we want to get an idea as to what type of equipment and care this person would need if they choose our services. We have an admissions nurse who goes out and meets with the patient and or the family wherever they decide. If it's in a hospital environment, we ask for permission and we meet them there. We can meet them in a local area at a home environment, but we want the environment and the surroundings to be as comfortable and as soothing, because we are talking about end-of-life care and end-of-life issues. We ask, what is it that you know about your medical issues or concerns? What has changed over time for you? What are things that you can no longer provide for versus what you were doing before? And what type of information has the provider shared with you about your current clinical care and condition? What we try to do is get to the point where we can address misconceptions about hospice care, where we can address certain care needs that the patient identifies at that time. What we also share during this information meeting is that VITAS is an interdisciplinary provider. We not only have a clinical side where it consists of a physician, nurse practitioner, nursing, hospice nurses who serve as the care managers. We also have the nursing aide, our psychosocial team, which is our volunteer bereavement, our chaplain, who serves as non-denominational, and our social worker. And all of these aspects of this interdisciplinary care fills in the certain aspects of that patient's life. Once the clinical information, the psychosocial information is reviewed, the patient is presented with an admission packet, consents to sign on with our services. And we always share that if you get to a point where you feel that this is no longer beneficial to you, we respect that, and we would initiate the process of discharging from our hospice services. We also share that hospice is indefinite. No one keeps score. And you may elect to choose hospice today and actually get better in what we claim is graduate from hospice services. And what may have been deemed as a terminal condition can actually be chronic in nature based on the type of care you received. But if you choose to elect hospice later on in your life, you are still able to receive that. All of that information is shared. It may not all stick initially, but it's repeated throughout the care. Once you're admitted to hospice services, there is a care plan that takes place between the hospice nurse, the patient, and the family to determine the number of visits that are made. We make a number of visits every single week, including telecare visits, FaceTime visits, in-person visits by myself and or the nurse practitioner. And as our video stated, we have 24/7 care. So our physical doors are open at 8 a.m. They may close at 5 p.m., but please don't be surprised if someone's still in the office working late hours. But then we go to our telecare system where there is an on-call nurse who's there to triage and there to provide guidance in regards to symptom management, caretaking, and sending out our on-call nurse to the various homes and communities to care for the patients.
Great.
And that care lasts, and that care increases, and as level of care increases, as your acuity increases with hospice care, and that level is adjusted every single day in order to meet the patient's comfort care needs.
Excellent. No, that was a great overview. And I would say to the audience, if you've got questions or comments or a scenario that you want to share, use Q&A. Feel free to raise your hand and we'll bring you on audio. But you'd mentioned medications a few times. Like, give us an idea on medication treatment for hospice, and then also, alternative. I know one of the things in all aspects of medicine now is alternative medicine, prescription treatments. Give us some thoughts on that.
My thoughts on that is I am 100% on board. I am a certified yoga instructor. So I do provide care from a non-pharmacologic approach, provided that the patients and the families are open to it. And you'd be amazed how breathing can alter someone's perception of pain, discomfort, and even anxiety. So we do have our own pharmacy, and we have pharmacy operations, and we have a pharmacist or a team of pharmacists that's assigned to each program with our VITAS organization. They are constantly reviewing medications, looking at drug interactions, making sure that they're important for the patient. We look at the medications to determine if they are still beneficial for the person that we're caring for. We also determine, based on studies which have shown that as someone is declining, even entering the active phase of passing on, we encourage and order medications that are used to provide care. They come in the form of Roxanol, which is liquid morphine, if the family is open to that. Ativan, Levsin, which is a medication to help with excessive secretions, Tylenol for pain and or temperature elevation, and bowel regimen. Those are some of the common medications. What I have found is that you can adjust certain medications based on what's needed for the patient. What I have also found is that oftentimes patients are reluctant early on to introduce those medications in their lives because it also gives a certain perception that they are passing on. So we meet the person, the patient, where they are today. And what we do is we provide pamphlets to them and we discuss it and we sit down. Our visits are very lengthy in the sense that we talk about what is it that you need to know about these medications that we are offering you at this point in your life? What is it that you need to know as you decline? And what are the symptoms that are associated with this particular clinical condition that you are facing? We no longer look at you as a diagnosis. We look at you as a person and what are your symptoms and how can we meet you there? So we do profile these medications electronically. They are prescribed and sent out via FedEx. And it comes with an education process as well. We do have the ability to order medications overnight. We are contracted with the CVS pharmacies and other local pharmacies in the area so that if there is an acute change, we can get those medications to the bedside emergently and immediately. We also connect with and work very closely with centers, facilities, to make sure that they have these common comfort medications on hand to care for the patients who are under the care of hospice and palliative care.
Great. No, that's fantastic. And Kate Daniels wrote, Dr. Richmond, I've been explaining hospice to providers and caregivers for 11 years and have never heard it explained so succinctly. Thank you. So that's great. And also we're recording this. So if you want to go back and for the providers out there to sort of, you know, we need language to explain this challenging stage here. Irene Jackson Brown says, what about VITAS and CBD? Like what is CBD and medical marijuana? I know one of the topics, it is one of the categories that seems to come up is end of life issues and pain issues and things like that. Is what's your viewpoint on CBD and medical marijuana and VITAS as well?
Yeah. Well, first I want to say big hugs to you, Dr. Irene Jackson Brown. We've worked with her extensively and it's been a wonderful opportunity. So medical marijuana, as we know, there are a lot of laws that are being passed in regards to the approval of medicinal marijuana in the area, DC being one of them. We've had extensive journal club meetings with our regional medical directors as well. And at this time, medical marijuana has not been federally passed, and we must abide by the federal laws at hand. If a patient has been issued medicinal marijuana by an outside provider, we honor that by adding it to our profile of medications that the patient is taking so that everyone is aware of the medications on board. Unfortunately, though, we are not managing it, but we are keeping a close eye on it to monitor symptoms if they are related to the patient and as they change. But we are here to support the outside care that the patient needs. We ask for full transparency so that we can add it to the list and we don't judge.
Mm-hmm. That's great. Have you had some patients that, that's interesting. And I think,
yes. Yes. And we do speak with their providers as well. And we let them know your patient that's under our service and our care has inquired about medicinal marijuana and ways to achieve that. And our psychosocial team assists with that aspect as well as making sure all the T's are crossed, the I's are dotted, and everything is well documented so that it serves as a very nice guideline as to the type of care the patient is seeking in order to receive their own comfort.
Great. I glanced over in chat and I see Patricia Dubroff is sharing the Death Cafe that she
Oh, yes.
coordinates. Does VITAS have support groups or things of that nature
Yes.
that they're aligned with? And do you have anecdotally or how do your families benefit from those types of programs?
We have a wealth of programs that are offered throughout the services. It's more so for outreach groups to provide supplemental care from a psychosocial standpoint. The ability to speak to someone who may be dealing with the same situation of having a loved one passing on. Our volunteer and bereavement coordinator is very, very big in the environment and in the community. Her name is Jasmine. And we are connected with a lot of organizations in the community. Once you have lost your loved one under our care, we offer at least 2 years of continued psychosocial support and bereavement care. And, we always talk pre-COVID, and now we're in COVID. We had opportunities with our wounded warriors. We had presentations where we honored our mothers, people who've lost their mothers, connecting those people with other patients who've lost their mothers or patients' families who've lost their mothers. So our community service and outreach is ongoing, and we also serve as a conduit to connect you to the proper outreach program for you.
Great. Ken Silverstein asks, why are you not providing your services in Maryland, or did I misunderstand?
Oh, yes. Well, Maryland is a certificate of need location. So unfortunately, at this time, we are not able to provide services in Maryland. We have encountered many patients. As you know, you can cross the street in certain areas in DC and you're in Maryland. We do receive referrals in our DC program, but the patient is presented with a Maryland address, or that is their primary address. What we do is we help facilitate and connect them with a provider in the Maryland area, so that it's not don't call us, we're DC. It's tell us what it is that we can do to help facilitate this, and we will assist with reaching providers in Maryland.
Great. But, and as you'd mentioned earlier, VITAS is a national healthcare
Yes.
company. Okay, great. Does VITAS have other, is it focused solely on nationwide, solely on hospice and palliative care, or are there any other sort of branches that they offer in other regions or locally?
For clinical care, Melissa
Yeah.
can add to that, but
Okay, all right.
the branch that I've grown accustomed to and know very well is the hospice and palliative care arm and access. Yeah.
Okay.
Yeah, and just to add on, we are actually just hospice and palliative care across the nation. We're in 14 states and the district, but we are the largest single source provider, which means we are focusing solely on our expertise, which is hospice and palliative care.
Great. And Tiffany Oscar asked, in addition to VITAS, what other hospice providers are in the DC area? What I can do is, when we follow up, we've got a list of those from Sourcebook, and I'll be happy to provide a link of some of the others. Tiffany. So great. Well, this has really been good. I'm sort of urging the audience to jump in with okay, and Esther Array says, Dr. Sonja, are you serving Virginia also? Yes, Virginia and DC.
Yes.
And you have an individual practice, correct? A medical practice?
Yes.
And that's based in Virginia, correct?
It's Virginia, Maryland, and DC. And it's primary focus, my individual practice, I'm licensed in all three entities, is providing care in the long-term environment, our older population who reside in the continuous care retirement communities and also standalone nursing home facilities and the post-acute care, subacute care facilities as well.
I know I'm kind of shifting gears a little bit here, but we love getting doctors and being able to ask you sort of operational questions. Any, has there been any interesting technology that you've either recently started utilizing with COVID-19 or technology platforms that you're kind of studying and you think might be something of interest to the audience? I know the remote patient monitoring is something that we've talked about quite a bit on these digital discussions.
I would say just in the face of COVID, the use of telehealth and FaceTime has been the one technological thing that I've relied heavily on. I've also found the importance of e-health, so documenting your notes electronically. So using, some facilities, they have the matrix system. We've also utilized Q-Shift. And so it's making sure that it's interchangeable, making sure that you have good records, because we as clinicians are now really working remotely. And so we have our computer and our FaceTime in front of us. And so good documentation and good history and documents that are uploaded has been my major thing. And the e-prescribing, the ability to e-prescribing. And that was one facet of care with VITAS that it has really, really cut down on missed medications, the increased time in getting medications to patients. So the turnaround time has been very efficient for care.
Let's see, we have a question regarding certificate of need, and what is a certificate of need? Can you explain that a little bit more?
Yeah, I will let Melissa, if you don't mind, explain the dynamics of needing that certificate in order for us to operate.
Sure. So certain states have regulations based on how many providers they will let in a certain area. So in our case right now, hospice and trying to enter Maryland. So until the state of Maryland decides that they would want another additional hospice provider, that's when we could then apply to be one of their providers. So we would love to be in Maryland, but not yet.
Yeah, and nursing homes are similar in most states, which is why you don't see any nursing homes being built, because most states require that certificate of need. It's a way that states use to sort of control the healthcare marketplace. But also, I may have been the one who kind of messed up on this, because I think I mentioned palliative care, but Susan Infield says, traditionally VITAS has provided hospice care. Is there now a separate palliative care arm? I apologize if I dropped palliative care and you don't provide that care.
VITAS does provide palliative care as well. In our Virginia office, we have the palliative care aspect as well. So it is available for everyone to receive.
And again, just because we've got such a varied audience, can you provide that brief sort of example of palliative care, hospice care? And again, guys, take notes on this. It's
yes,
I
would say that it is very challenging to tease out the two. I would say that the type of care is incorporated. So palliative care falls into hospice care. Palliative care is generally initiated early on in the patient's clinical course or clinical care, and you're managing an aspect to provide comfort for them. You may not have deemed this particular person that you're caring for as a provider that the prognosis is 6 months or less. What you're saying is that you have symptoms that require management and you're looking for comfort care so that you can continue with the treatments that you desire. When you take on the role, or when you become a provider in the aspect of hospice care, what you are saying is that my direction is now shifted to solely comfort care. And unfortunately, the interventions that I've put in place will not cure my condition, may actually be causing me more distress, even harm or discomfort. And I have accepted the fact that it is more than likely, it's highly probable that I unfortunately may not be here within the next 6 months. It's not a hard and fast rule. What it's saying is that these type of interventions that I've been seeking and the type of treatments that I've been seeking will not cure the situation or resolve the clinical course that I'm taking. And it may also introduce other complicating factors. Many people, many patients who start off with palliative care, they do eventually go down the road of receiving hospice care. But there are very few, or even some, I'm not even going to say very few, but there are some people who also continue on with palliative care and they do recover. There are possibilities in both scenarios. We are here, my area of medicine here is providing the hospice type of care.
Great. Very, very good. Jennifer.
I could add really quickly, just to clarify, the Virginia palliative care programs right now, they are both inpatient based. So we do have palliative care and they're within the hospital setting for inpatient. But VITAS does provide palliative care throughout the country.
Great. And Jennifer Brown has her hand raised. And so I've just asked for her to be unmuted. Jennifer?
Hey, Steve. Thank you, VITAS. This has been excellent. My understanding is under the current COVID situation, the certificate of need for SNF beds in the District of Columbia has been waived. So that, and I don't know if that waiver pertains to Virginia and Maryland, but the response to the potential of an overflow of patients, the SNFs in DC have the flexibility to open SNF beds currently without a certificate of need. I don't know if that applies to hospice care or not, and I don't know if that applies outside of the District of Columbia.
Oh, good. Really good. I think this topic of certificate of need would make a great discussion for a future, but thanks for sharing that, Jennifer. And then somebody said they heard you say earlier, graduating from hospice, not the end necessarily, more care given, please explain. And I think you just did in that response.
Yeah, I can elaborate on that. There are some people who are taken under care for hospice, and once receiving our care, what may have been deemed terminal has now become chronic in nature, where symptoms are managed. They are now being treated with medications that are supporting their symptoms. They're more comforted. They've increased their activities of daily living. You're actually improving. And so what we then would say is that at this time, we are suggesting discharge from our services due to extended prognosis, that we would now be surprised if you were to pass away within 6 months or less. We are always here to provide care, but abiding by the guidelines that are set forth through Medicare. Once our viewpoint has changed, once we've identified that you are actually improving, we do assist with that transition back into the community where you can become reincorporated with your outside primary provider, or I can continue being your provider. We order the necessary medications that you have in hand. We set you up with the home health agencies if that is what you need at this point going forward. And we will continue to support you if and when you need to come back and receive services.
Great. Because you brought up Medicare, Susan Rannick has a comment. I think I think it is important to stress that hospice care is also an insurance benefit, like a health insurance.
So, right. So hospice, I mean, it's all part of the Medicare benefit. So everyone deserves to receive hospice care. We also do take patients under care who are not insured, and they receive the same care. We provide the visits from the physicians, the nurse case manager, our psychosocial team, our volunteer and bereavement services. But yes, everyone deserves to receive hospice care if that is what they choose. And with VITAS, it's regardless if you are insured.
Oh, wow. Let's see, Mamela Drake asks, how can a social worker or nurse connect with a patient at end of life stage when FaceTime is in use?
When FaceTime is in use?
Yeah, I guess
Okay.
maybe how that's done.
It is challenging.
Yeah.
Yes, I would say this adjustment, we're having a meeting. I'm assuming that we would have probably had in person. We've all adjusted in different ways, but our social worker as well as our chaplain are now making visits in the homes, provided that the families are open to it. What we do is we develop a partnership. So if the nurse case manager is making her home visit, but the chaplain and or social worker is not allowed to come into that home, we set it up via FaceTime on our VITAS issued cell phones. And everyone's gathered around and we talk about the issues at hand that are discussed extensively. It's been quite effective. Music is played sometimes it's life review, it's discussion of the current situation, family dynamics as well. I think, the whole world has made that shift and that adjustment, and family members are open and welcoming to continuing to receive that care, even if it's through FaceTime and telehealth.
Great. And let's see, comfort measures. How do you know if a patient is in pain?
So sometimes patients are in a position where they cannot verbally say pain. We have a scale, it's called a pain ad scale, and it's a nonverbal signs of pain. And so this is when we're looking at signs and honing in on our skills as just human beings and interacting. And first and foremost, it's good, listening skills. And sometimes I may overlook the caregiver and miss an opportunity to hear about pain. So I often have to take a step back and listen, because the caregiver is the first person that can tell us what's going on with their loved one. They know patterns. But if I'm looking at the patient themselves, I look for facial grimacing. If you're tearing, if you're even retracting or retreating when that type of care is being given, clenching your jaws, clenching your mouth, or sometimes even crying out in discomfort. I notice it during turning and repositioning, notice it during transferring in and out of bed, as well as if they unfortunately have wounds that need to be addressed. So these are all signs of nonverbal pain assessment that's documented not only by myself, but the nurses. I often utilize not only the nurse, but the aide that's there providing that intimate type of care for the patient, as well as the psychosocial team. Pain can even come out as anger sometimes as well.
Yeah. Mike Perlman just asked a really good question as we're kind of wrapping down. I wanted to make sure to kind of skip him ahead of the line. DC has legalized medical aid in dying. Does VITAS get involved with this aspect?
Yes, we do. We do. We're highly involved with it. I trained at George Washington University, and there's a leading physician at GW who is certified to assist with that for patients. As you know, it passed in 2018, and since then, we have been a part of more than 2 people choosing to go down that path. We do have a system in place. We have our death and dying arm where we have personnel from VITAS who assists us when family members state that this is the process, this is the goal for them. First and foremost, you have to have an established illness that unfortunately would put you on hospice care. More than likely, you would be passing away within 6 months or less. You have to have all of your faculties. So if you undergo a thorough psychiatric evaluation, you also identify your wishes with this physician who is licensed and certified to provide the medications. So once you identify this is what you want to do on day one, it must then accompany a written letter that this is your choice that you want to make. And then 15 days later, you have to still say the same thing, the same presentation. You must still present the same way. You still go through the psych evaluation. We at VITAS are here with you along the way because there are still some comfort aspects that still need to be addressed, psychosocial aspects that still need to be addressed. Once those medications are ordered through the pharmacy, the patient must collect those medications. The patient must physically be able to take those meds and ingest it independent of anyone. We set the environment in a caring and natural environment. We are here not only for the patient, but for the family. Many members of our team in the DC program have attended this process, and it is done with love, it is done with gratitude, and it's done in a very peaceful and supportive environment. And we are very fortunate to be a part of that and to assist with facilitating the connections with the providers in the community and also being there.
Yeah, and again, another topic that when we used to do live events, we had speakers on, and it's very engaging and generates a lot of conversation. So
Yeah.
Thanks for, again, just really summarizing that. So we're getting to one here, so I'm gonna wrap up with a few more questions here. Hospice care directive, can the patient say what care they want and do not want? And I guess
It's an individualized care plan. So when you elect hospice care with VITAS, we don't say we stop all treatments. It's an individualized care plan. But what I do ask, not only the patients and the families, what is the outcome that you desire? How has this particular treatment course that you have taken under thus far benefited you? So it's a conversation, but it's you come first and your desires and wishes come first. And my goal and our goal is to meet those wishes and desires.
Follow-up question on the aid in dying from Susan Infield. Does legalized medical aid in dying fall under the hospice benefit? The message used to be nothing to either artificially prolong life or hasten death. How does that fit?
So when you do elect the death with dignity course of care, the provider, the physician who's licensed, they do connect you to a hospice provider and company. The idea and the premise is to have a hospice support you along the way and to be a part of that care. So yes, it is carved out, it is documented, it is part of our care plan as well.
And let's see, caregivers and family members, anticipation of grief, dying family member in hospice. How do you care for health and well-being of all holistic care for all during this season of life change? So going beyond the patient, the family, and you've addressed that throughout the program, but maybe share some thoughts, and that'll be our closing question.
As I shared, I think for me, in my journey, my medical journey, even my own personal life journey, I bring everything back to my breath work and my breathing. And that's what I encourage for a lot of family members. What I would say is listening to what people are really saying when we are brought into their lives to provide this type of care. And as I always say, end of life care is a part of wellness as well. There's a way to carve it out in a way that it is supportive. less is best when it comes to medication sometimes. But I also encourage that we do everything that we need to undertake to provide comfort care and peace of mind. And we do it in an interdisciplinary approach.
Wow. Well, thank you so much. And,
Thank
just
you.
in closing, I'm just going to say Susan Rannick, who's always got a way of words. Also important to stress, not everyone on hospice dies. It's a simpler way of saying what you just stated. Sometimes people do improve, and then hospice is recommended. So great way to kind of close this out. And we'll share your contact info. We'll share Melissa's contact info, and we'll have a recording. We'll have a transcript of the chat. And you got some great comments in chat that you can read after this.
Thank you.
Thank
you, everyone.
Dr.
Thank
Sonja. So thanks a lot, Melissa, for bringing this together.
Thank you so much, Steve. We really appreciate being able to be a part of this.
Okay, great.
Dr.
Big
Richmond.
hugs to everyone.
You bet.
Thank you, everyone.